We are going to talk about one of the most fascinating things that I get to teach you about, and that is hypertensive disorders of pregnancy. It's the most commonly encountered medical condition in pregnant women and complicates 10% of all pregnancies. So we're talking a large percentage of our pregnant patients that are dealing with this. When we talk about hypertensive disorders, the thing that's interesting is that we don't really know what causes them. When we start talking about preeclampsia and HELLP syndrome and some of those other disorders, it's called the disease of theories because nobody really knows what causes this to happen. We do know there are some risk factors, and there's different risk factors for the different conditions, but generally speaking, risk factors for any type of hypertensive disorder in pregnancy, it's going to be chronic hypertension, diabetes, Black ethnicity, obesity, and age over 40. The four different types of hypertensive disorders that we're going to talk about are chronic hypertension, gestational hypertension, preeclampsia and eclampsia, and HELLP syndrome. That's all part of the same thing. And chronic hypertension with superimposed preeclampsia. So those are the four different types, we'll say, of hypertensive disorders of pregnancy. First, we'll talk about chronic hypertension. So that is exactly what it sounds like. Blood pressure, that's high. That's not blamed on the pregnancy. Okay, so if a patient has hypertension, which we define as blood pressure greater than 140/90 before pregnancy or before 20 weeks gestation, that's that key time that if it happens before that, we can't blame it on the pregnancy. So hypertension before 20 weeks is called chronic hypertension. Okay, if it's severe, so greater than 160/100, we'll use some antihypertensive medications. That's it for chronic hypertension. Those patients, we're just going to try to manage their blood pressures and assess for the development of preeclampsia, which is a different disorder, which we'll talk about in a little bit. Next is gestational hypertension. So if we think about these hypertensive disorders on a spectrum, there we go. Okay, so we'll say chronic hypertension is like at this end of the spectrum. Usually it's the most mild. We can manage it with meds. Next is gestational hypertension. So that is hypertension, so blood pressure over 140/90 in a previously normotensive woman without proteinuria after 20 weeks gestation. Okay, so we know it's after 20 weeks because if it was before 20 weeks, it would be what? Chronic hypertension, right? So we're after 20 weeks gestation. Now this patient has hypertension, but she has no other issues going on. She doesn't have any protein in her urine. She doesn't have any organ involvement. It's just hypertension. So that is gestational hypertension, pregnancy-induced hypertension. For a diagnosis of gestational hypertension, you need 2 blood pressures. So blood pressures that are over 140/90 on at least 2 occasions, 4 to 6 hours apart. Okay, so we don't just check a blood pressure once and diagnose it. We need 2 different occasions, at least 4 to 6 hours apart, with a blood pressure over 140/90. The next subset we're going to talk about is preeclampsia and eclampsia. I would recommend watching this YouTube video when you guys get a chance. Preeclampsia is new onset hypertension accompanied by proteinuria and or maternal organ dysfunction. So that means that this patient has hypertension and it's affecting her organs. Okay. We no longer just have hypertension, because if we only had hypertension, that would be what? Gestational hypertension. But now we have organ dysfunction, shown by either proteinuria or abnormal liver function tests, clinical signs and symptoms of the disease. Most of the Most of the issues arise in the cardiovascular, renal, CNS, and hepatic systems. So those are kind of the ones that are hardest hit by preeclampsia. We see changes in the kidney function. We see changes in the liver function. We see changes in the central nervous system. Those are all the changes that would lead us to think that this patient has preeclampsia. Again, the cause is unknown. We do know that it's kind of a two-stage disease process. So the first stage, the major issue we'll say is vasospasm. So we get vasospasm, which then causes all of these other issues to these end organs. So this little chart kind of just shows you we've got endothelial cell dysfunction. So that's kind of the first thing that happens, which causes increased permeability and capillary leakage, intravascular coagulation, and vasospasm, which then causes proteinuria, hemolysis, hypertension, decreased placental perfusion, glomerular damage. All of these other things happen because of the original endothelial cell dysfunction, which then again trickled down to the increased permeability and capillary leakage, intravascular coagulation, and vasospasm, which because of those issues causes all these other things. So again, the first stage was vasospasms, which results in elevated blood pressure and reduced blood flow to the brain, liver, kidneys, placenta, and lungs. Sounds kind of scary, right? So what do we do if a patient has preeclampsia? We know they have this condition. We know they have hypertension. We know their organs potentially, so their kidneys, their liver, their brain. We know those are involved in the disease process. So what do we do about it? The cure is always delivery of the placenta, okay? So there is no medication we can give somebody to cure preeclampsia. We can manage the pregnancy and manage the symptoms depending on the severity of the condition and the gestational age and its effects on the fetus. So for preeclampsia specifically, so not just hypertensive disorders as a whole, but specifically preeclampsia, your risk factors are first baby, age younger than 20 or older than 35, so too young, too old, prima gravida, so first baby, multiple gestation, so twins, triplets, in vitro fertilization is a risk factor, obesity, African American ethnicity, and first pregnancy with a different dad also actually is a risk factor. So when we talk about preeclampsia, there's two types. It can either be preeclampsia without severe features or preeclampsia with severe features. We manage them much differently. So preeclampsia without severe features kind of is exactly what it sounds like. We have preeclampsia, we have the diagnosis of preeclampsia, but it's not severe yet. The damage to the organs is not bad yet. We know there's some involvement, but it's not severe. So women who have no signs of kidney or liver dysfunction or coagulopathy, we can manage them pretty conservatively. So the goal is for the pregnancy to progress as long as possible. The goal is to get this baby as much time inside to grow as we can without putting mom's health at risk. So these patients, again, so preeclampsia without severe features, these patients we can typically manage at home. So modified bed rest, we want to just keep everything kind of calm. We don't say complete bed rest, but we do say limit your activity. Prenatal visits and testing does increase in frequency because these patients, we need to keep a closer eye on them. This pregnancy is now high risk. It's no longer normal. So the patients will be instructed to monitor their blood pressures daily at home, obviously at the same time every day. And we want them to report any increased measurements. They'll do a fetal kit counts. This says daily, but really more often than daily. Because remember I said with preeclampsia, you get decreased blood flow to the organs, the uterus being one of them, and the placenta. So if we have decreased blood flow to the placenta, we are concerned with our baby not getting enough oxygen and nutrients. So fetal kit counts are really important for these patients to monitor their baby's health in utero. If these patients are hospitalized, we're going to watch closely for signs and symptoms of the severe features of the disease, frequent blood pressure measurements, non-stress tests, ultrasounds, and expected management, which is basically just watch and wait until 37 weeks. So 37 weeks is kind of the cutoff of when they say, nope, delivery is more advantageous than staying pregnant. So at 37 weeks, patients with preeclampsia will be induced. During labor, we're just going to watch to make sure that the disease isn't progressing to the severe features of preeclampsia or eclampsia, which includes frequent blood pressures, maintaining a quiet environment, and magnesium sulfate is not recommended for preeclampsia without severe features. So without severe features, we're going to watch and wait until 37 weeks. And then our main thing is make sure these patients don't get worse. Preeclampsia with severe features is managed much different. So treatment for this is going to be individualized based on the severity of the disease and the gestational age. A patient who is at the 24th week of their pregnancy will be managed a bit differently than a patient who is at the 35th week of pregnancy. We will give them antihypertensives. Labetalol is a good one. That's usually what they start with. Prenatal aspirin therapy has shown to be possibly beneficial. Betamethasone before 34 weeks. So patients with preeclampsia with severe features, we anticipate will deliver a preterm baby. How preterm? That depends on how sick the mom is. But anytime we anticipate the delivery of a preterm baby, it's important that we administer betamethasone, which is a steroid, to mom, which then works to enhance fetal lung maturity. So if we're delivering a preterm baby, we want to do everything we can to help that baby's lungs mature faster. So we will give moms betamethasone. It's an IM injection. They get 24 hours apart. So hopefully we can delay delivery for at least 48 hours to get those steroids on board. Preeclampsia with severe features, they will get IV magnesium sulfate. That is a seizure prophylactic medication. With preeclampsia, we are trying to avoid it progressing to eclampsia, which is a seizure. Patients will get mag sulfate IV, which hopefully will prevent the disease from progressing to eclampsia. Magnesium sulfate is a high-risk medication. It's given as a loading dose of 4 to 6 grams over 15 to 30 minutes. So that's a huge dose of magnesium over a really short amount of time. And then the maintenance infusion is usually 2 grams per hour as a continuous infusion. There is a high risk for magnesium sulfate overdose or toxicity. So it's important that we have calcium gluconate easily available in case the patient does get toxicity or overdosed. And that is given just as a 10 ml IV push over 3 minutes for respiratory depression. So with magnesium sulfate, as the blood levels rise, patients start to exhibit certain signs of that increasing level. So first they lose their deep tendon reflexes, then they get respiratory depression, and then they get cardiac abnormalities. So as that magnesium level rises, we start to see changes in our assessment. So it's really important to be doing close hourly assessments of those things, deep tendon reflexes, respiratory rate, things like that. If a woman is seriously ill, An unstable cesarean birth will be done if we just don't have time to wait. Babies whose moms received magnesium sulfate either before birth or during labor tend to exhibit respiratory depression at birth. So magnesium makes moms feel really tired and lethargic because it acts as a smooth muscle relaxant, right? So it kind of just makes you feel yucky. It makes babies feel the same way. So it's important to prepare for that at the birth, knowing if the mom was on magnesium sulfate for preeclampsia, the baby might be born with some degree of respiratory depression. Like I said, eclampsia is the development of seizures in a preeclamptic patient. Obviously, it's a medical emergency. Treatment follows the basic principles of airway, breathing, circulation. So we do not really treat these patients any differently than we would any other patient that has a seizure. Call for help, turn them on our side, keep them safe, keep the airway open, suction after, time the seizure, give oxygen after. Also, after the seizure stops, we will need to assess the fetal heart rate. During the seizure, we're probably going to have a prolonged deceleration because that whole uterus is going to be contracted. However, after the seizure stops, the fetal heart rate should come back up. So again, with management of preeclampsia, let's rewind a little bit to preeclampsia without severe features. So this is that one where we're kind of watching and waiting. Like I said, women can typically be monitored at home as long as they have a good understanding of the disease process and what they need to be watching for. Frequent visits with blood pressure monitoring and non-stress tests to make sure that the baby is doing well. With severe features, now it's a whole different ballgame. So these patients are hospitalized, on bed rest, with a dark room, seizure precautions, antihypertensives. So that's going to be IV hydralazine or labetalol, glucocorticosteroids to enhance fetal lung maturity, continuous fetal monitoring, and then close assessments of level of consciousness, headaches, vision changes, things like that. Hourly INO because we're worried about kidney damage, right, and fluid overload. So in that aspect, we're also assessing for signs of pulmonary edema. We're doing labs, so AST, ALT, CBC, and coags, because we know that the liver is potentially involved. And then after the birth, remember I said that the cure typically is delivery of the placenta. So these patients will be on magnesium sulfate for 24 hours after delivery. And then typically they get better pretty darn quick. With magnesium sulfate, your therapeutic level is 4 to 7 milliequivalents per liter. Like I said, we're going to closely assess for toxicity with respiratory rates, deep tendon reflexes, and urine output. If toxicity develops, we're going to administer our antidote, which is calcium gluconate. And most hospitals in their magnesium sulfate protocol will ask for hourly assessments of deep tendon reflexes and respiratory rate, because those two assessments should tell you what your magnesium level is. Some facilities will have you draw every 4-hour magnesium levels to make sure that your level is therapeutic. Here's just a chart kind of outlining the differences between preeclampsia without severe features, preeclampsia with severe features, and eclampsia. Now, HELLP syndrome is typically associated with preeclampsia with severe features, so it's a type of severe preeclampsia. It stands for hemolysis, elevated liver enzymes, and low platelet count, all stemming from the liver involvement. So it's a variant of preeclampsia with severe features. 20% of women diagnosed with that will develop HELLP syndrome. It is considered a life-threatening complication, And these patients are at risk for DIC, cerebral hemorrhage, placental abruption, acute renal failure, and potentially death. Um, so as far as the pathophysiology, we kind of talked about it at the beginning, but you get abnormal vascular tone, vasospasms, and clotting issues. Hemolysis, because of the red blood cell damage as they pass through those damaged blood vessels. Elevated liver enzymes are the result of decreased blood flow to the liver, and then low platelets because of the vascular damage and the vasospasm. So you get thrombocytopenia. Management focuses on stabilization of blood pressure and assessment of fetal well-being to determine when we need to deliver. Patients with HELLP syndrome will deliver soon. It just is a matter of how soon. So that will be determined based on the severity of the disease. So how high are the blood pressures? Can we manage them with medication? How bad are her labs? What's the gestational age? Like, do we have time to wait? Or is this baby mature enough that it will do fine outside of the uterus? And in that case, we would just deliver right away. And how sick is mom? So we'll give rapid acting antihypertensives, the same ones as with preeclampsia with severe features, because again, this is a type of that disease, and that's hydralazine or labetalol, potentially a platelet infusion, magnesium sulfate for sure, steroids to help fetal lung maturity, and these patients should be transferred to a facility with a NICU. Most of the time, HELLP syndrome does develop preterm. So these babies, most of the time, are being born preterm, knowing that they will have to overcome some issues. When we're taking care of patients with HELLP syndrome, we need to be doing really, really good close assessments. We need to be aware and kind of on alert for any complaints of nausea, malaise, epigastric pain, headache, vision changes, and doing our head to toe assessments frequently, listening to their lung sounds frequently, assessing for pulmonary edema. Let's see, nursing management for patients with HELLP syndrome is the same as for patients with preeclampsia with severe features. Closely monitoring for changes and prepare to transfer to the appropriate level of care. That's it.